To a Cisco meeting. You are entering the meeting now. This meeting is being recorded. You are the only participant.
Yeah, I'm going to test sound, see if this actually works. If it does, it's going to make my life a lot easier. Can you hear me? 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Plus, I can't get the video to start, so that's not good either. Got a whole bunch of videos in this presentation. Okay. Hi, Jen. Hello. Yes. Yeah, the presenter view. I'm not sure, because what's funny is I'm seeing just the presentation slide on my big screen in here. Okay, let me see if I can figure that out.
Yeah, gotcha. Okay, I've got it. In the top, there's something called the display setting, and it said to switch it, and it switched. Give it a oh, but you know what it did is it switched it into my the screen. Yeah, that's not what I want. Yeah, except that in the room, it's put the notes in the next slide on the big screen. Yeah, no, this worked. This has worked. And you can hear me okay? But I do have there's so there's a video just at the beginning here that's not starting. Oh, I just tested it. It is starting. Oh, error. Please try again. All right. Yeah, give it a minute because I'm past that point, I think. Ah, yeah, I'm having problems with the video. Yeah. Well, that's the problem. She sent it to me through a Google Doc. Hmm. The thing is it was before I left my office. I checked without internet, like I just checked the video presentation and made sure that they were all linked. Yeah. Right. I know, and I've actually spent about 5 hours working on her videos this morning trying to make these all link right. So um, it's going to be real problematic because let's see if this one works. Okay, that one works. Oh, she's got like 12. That one works. Yeah, yeah, I can hear that. Okay, well, it looks like it's only one video. It looks like it's only this very first video. Well, she sent it on a Google Docs, so or Google Drive, so I wasn't able to view or preview it. I only was able to download it. It took about 20 minutes because of all the videos. I'm just tempted to just switch over to the other computer because it's working on the other computer. All right, let me just see one more time and make sure that the rest of these are working. We're not, are well, we are broadcasting because you can see all this, right?
chat's pulling up. Let me tell you really fast about on the stream.
Yeah.
If anybody wants to do a chat, does anybody?
Yeah, we've tried to do chat before.
Okay, it's really easy now. We've got a brand new system.
Are you seeing my presentation view again?
Yep.
Yeah. I don't know. That keeps going. That keeps flipping back.
So chat is really easy. So I want to just right next to all they do is page.
Okay, and this is when you sign in to the UTN website. Okay.
It's super slick. Been working on this quite a while.
I'm having all sorts of problems now.
Change that computer.
Yep. Right. During the presentation.
And save. And
Although I'm fearful that these are going to do the same thing because I tested both of them at my office and they both worked fine. But now we'll see. Seriously, I've been working on her videos all day long. That's exactly what's happened here. The problem is she did not send me the original video. So thank you for being willing to work on this. I hate this project. I'll be honest. You're the only bright spot in it. Oh yes, he does a wonderful job too. Oh. No, I want to give you personal props, but I will say UTN is the only bright spot in this horrific project that I absolutely hate. I am excited about that. It's been that I've always enjoyed chatting with you. All right. Yeah, so the other computer is primaries, and we spent a whole bunch of time clearing all the firewalls from it so that we could access it. Sorry, I'm getting all sorts of errors on this computer, so let me just read through these for a minute. Trying to sign in on the telehealth network, and it's really slow. You still getting a live feed from me? Uh-huh. Okay, so normally when I log into Utah Telehealth Network, sign in after doing the page, start the meeting, and it just has contact support. Okay, wait a minute, I'm gonna restart everything. Shouldn't
If you're the meeting host, enter the host PIN followed by pound. If you're not the host, press pound.
Your content, your screen. That's an encrypted flash drive, so I have to sign it. It's a little man with a red face, if you see that at all. All right, now let's see if we can get these to open up. We don't need to worry about that.
Okay, I see you.
Should be able to hear me too now.
Here you go. And I see Intermountain Healthcare. Nice.
I'm opening the PowerPoint as we speak. Hillary and I have both emailed all of the crews, and neither one of us got any word back. So I may be your only audience.
I love that.
But I promise you, we get quite a bit of traffic on these days.
I don't like doing that.
It's like, you're not your thing, huh? All right, let's see if this one works better. I did put a lead slide and an end slide on your presentation. This is the lead slide here. And that's just what we use to open the webinar. And then the very end, after your questions slide, make sure you click one more time because it shows people how to get their certificate. Okay, so first video we were having problems with is this first one. We've been getting this, and then we get an error. Oh, it plays! Oh my gosh! It plays, Jan. This one plays. Something's up with the other computer. We're testing videos. Now you know that when you push click, Sarah, you know that when you push click, it just advances your video. So you need to actually click on to go to the next slide. So you don't need to do that. So like for this slide, video right here.
Yeah, I'm gonna hang up. I think
Okay, sounds good. Thank you so much, Jan. You're awesome.
so are you.
We'll start the chat and be watching online. We have chat this time. Welcome, welcome. I have my sign-in sheet right there. So some of the videos, just click to start. But I noticed some of these videos.
Expand panel to show video?
That is actually part of the webinar.
Okay.
I had a lot of trouble with these white ones. The ones
Sorry.
that were linked. Come on, I had them all.
There's one.
These two and those, we've got like 3. These ones are add-ons. Okay, good. They're coming. They might take, so you might like to be like, hey, let's play.
Okay.
But let me show you what they do. This is a little funny because they're web line. Oh, here, I'm going to mute us so nobody's here.
Why don't I do that anymore? Every time I see
Hi, everyone. Thank you so much for tuning in for our monthly EMS conference, and thank you for everyone who's here live and those of you online. Today, we're going to have Dr. Sarah Becker, who's one of our pediatric emergency medicine physicians at Primary Children's, talking to us about some respiratory topics. Those of you online, I think we do have the chat function working, so if you have any questions, you should be able to type it in. Sign in with a nickname so we can say who it's from, and we can answer those questions for you. And for those of you online, there is going to be a final slide that'll tell you how to get your CME credit. It'll involve just answering a couple questions and getting back to Tia. So thank you guys so much. And here's Dr. Becker.
Hi guys, everyone. Thank you all so much for coming out to listen to this talk. I'm sure you probably hear this all the time, but I'm just in awe of you guys. I'm so grateful, and it feels like an honor to be able to talk to you about this stuff. Hopefully I'm not telling you stuff that you already know, but you know, we have so much resources at Primary Children's, the emergency department. It's pretty easy to do what we do, but you guys go in, sight unseen. It's amazing. So thank you. Well, I'm here to talk to you a little bit about the pediatric. Okay. Okay, cool. The pediatric airway, not so much about like intubating airway, but just how to conceptualize the pediatric airway when you're in the field. That will help triage and treat patients. Sadly, I have no disclosures. I am working on this. But our objectives today are, number one, I think this is the number one objective that I wanted to get out of this talk, which is to approach each quote breather. We call them breathers. I don't know if you guys do, with an open mind, not to think about them all the same. They don't all have the same thing. And by doing that, I think we'll provide better care together. Just going over some quick talking points about the differences between the pediatric and the adult airway. Ways that we can differentiate sick versus not sick. The way to I think about respiratory illness is to target the pathology location. And we'll talk a little bit about why the airway is so tricky and why the location is so important, and the treatments. And we start off with a case. You guys are called to the home of a 6-year-old male who has had 2 days of fever, vomiting, and now several hours of increased work of breathing. When you arrive, your patient is listless with the following vital signs. Temperature is 38.5, heart rate 144, blood pressure 90, okay, sorry, 98/60, respiratory rate 45, and he's studying 96% in room air. You talk to the parents and you get the history that he doesn't have any history. Dad has asthma, so he tried giving this little child some of his albuterol, but it didn't seem to have any clinical change. I have to click on this, right? Okay. You walk in, and I mean, this patient is clearly not in a home in Salt, but like, this is what he looks like. Now, what do you guys see? Right, accessory muscles, retractions, just sick. He's sick, like sick versus not sick. Okay. Oh, just kidding. Okay. So when you walk in and you see a kid like that, what are the things that are kind of popping through your mind? Yes, absolutely. Amen. Yeah, we want to get moving. Are there any things in terms of like what you think is likely going on based on like that he's febrile, he's tachycardic, he looks ill? Things that you're thinking about could be his diagnosis or potential diagnosis? That's perfect. So actually, you can go to the next slide if I know how to do that. So his lung sounds are cleared. Tachypnic with moderate respiratory distress and his capillary refill is 4 seconds. So now, does that change anything for you, or what are you guys still thinking? Okay, that's for sure one of the things that's going on. But I think for me, the first case, the point I wanted to bring home is if you checked his blood sugar, it was greater than 600. So that kid, even though we're talking about respiratory distress in the middle of winter, is not necessarily a breather. And he's breathing, but it's to think outside the box as to what else could be going on with this kid. Absolutely, metabolic acidosis, and he's compensating. It is exactly what's going on. So we need to look at each breather with a fresh set of eyes so we don't get that tunnel vision. I mean, I get it myself in the emergency department all the time, especially right about now. You know, I have compassion fatigue for bronchiolitis. And so we start to just always think every kid has bronchiolitis, but it's just not true. So now we're just going to go over some of the anatomical differences between a pediatric and an adult airway. Because for me, I don't know how you guys think. For me, my IQ is not so high. I need to like see things. I need to conceptualize what's going on before I'm just going to intervene. I know sometimes you don't have the luxury of all that time to do those kinds of things, but I think it's helpful. So just some major differences between pediatric and adult airways. They have really big heads. Not that I should be talking, but they have big heads. They have big fat tongues that can obstruct their airway. They have a short neck. And so that because their neck is short, their larynx is a lot higher than you would imagine in an adult airway. Their airway is also very anterior. As they're bobbling or toddling around with their big head, they hold their trachea more anterior and hopefully no facial hair. And they have a different physiology of desaturation. So I'm sure you know this too. Kids look great until they don't. And they essentially have the physiology of like 150 kilo adult male. They're fine until they're not. And so they crash pretty quickly. This kind of gives you some more detail as to some of the differences between the pediatric and the adult airway. This is also helpful if you guys are intubating in the field, which I'm not sure if you are or not. But the large occiput is important even when you're not intubating a child, because a lot of times, and we'll talk about this ad nauseum during this talk, is that head gets in the way of a lot of things even when they're not getting intubated. If our gestalt is, oh, they're sick, I must lay them down so they can be peaceful with life. And that's just unfortunately not the case. If you lay them down flat without anything underneath them, that big head pushes their neck forward, pinching off whatever reserve they have in that airway that they're struggling with. Actually, this picture, I can go back to this. In adults, we do the head roll, and that seems to kind of put everything in just so alignment. But for kids, especially in this age group, our goal is to put ear to sternal notch, even when they're not getting intubated, just to maximize the patency of that airway. So sometimes you have to kind of play with the shoulder roll when you're repositioning a patient just to get that airway open optimally. And honestly, I think the reason that it's really stressful why people come to pediatric talks is I think the stakes are higher. It's a high stress situation. And so it's just about thinking about things a little bit more methodically. At least that's what I try to do when I'm in the emergency department to target the optimal treatment. I think in every pediatric presentation that you guys get, you get the pediatric assessment triangle. And every pediatric emergency doctor that I know, when they first talk about the pediatric assessment triangle, says, this is the dumbest thing I've ever seen, I've ever heard of. What is this thing? But when you really dive into it, I think in particular with, the venues that you're working in, the appearance part of it is huge. We all know ABC, every breathing circulation, but the appearance, you can get so much with enough experience walking into a room within 15 seconds, know what you need to do. Appearance, I think, oftentimes we use another mnemonic. I don't know if you guys have heard of tickles. It's not even spelled the right way, so I don't know how helpful that is. But T being, I already forgot T. Hold on, I have it written down. Tone. Thank you. Thank you, Tia. Tone is a patient vigorous, moving their arms around, making eye contact, crying, not crying, listless. That to me is the tone is probably one of the most important things that I use to determine whether I'm going to do something right away or not. The other thing is interactiveness. So, there's this, Mike Mishra calls it like the 1,000-yard stare when you kind of come in and you see a kid who's just staring off like you're not even in the room. Kids don't do that. That's not normal for them. So that's a sign that something more is going on. The C is for either crying or consolability. In general, parents can console their children eventually, given enough effort. And so if they're inconsolable, a kid who doesn't have a lot of other higher cortical function is trying to tell you something is wrong. And then we skip the K verticals and go to L, which is, I'm already forgetting to you. We don't use these mnemonics often. Oh my goodness, I have written down. Please forgive me. Oh, look. So that's that look on their, that, did you say that? Oh, makes it more fun that way, right? And then the last one is speech. So kids that are verbal, are they talking to you? Are they interacting with you? Ask a question. If they don't give you an answer and they're just staring at you, there is lack of something internally that's driving them to interact with you that way. So I mean, that's the thing is like with airway, I think, and I want to emphasize this to everyone, anyone who's listening and who's here, this is your wheelhouse. Like, this is your jam. I don't need to tell you this stuff. This is just more reinforcing what you already know to remind you of some little tips and tricks to like get through these situations. So I sometimes will use a checklist. I actually do use this sometimes when I get freaked out by a patient. Like, okay, sick or not sick? Like immediately 15 seconds in the room. Are they sick? Are they not sick? Is there airway breathing? Are they breathing? Are they circulating? And then do a quick assessment. Come up with a couple of things that could be, do something, and then reassess whether that intervention did anything. We're gonna do that a couple times here. I want you guys to watch this video and then tell me, using whatever mental pathway that you use, what you think about this kid. What does their appearance look like to you? Yeah, he's got good color. He's vigorous, smiling at whoever's taking the pictures. It's hard to really tell work of breathing because we're only getting from the nipples up, but overall, you're getting a pretty good feeling that this kid isn't terribly sick. And then what about ABCs? His airway's patent. He seems to be breathing. His circulation, his color is good. Do you think there's anything really, like when you walk in, are you freaking out about this kid? Or are you gonna probably do some reassurance to families that things look okay and you can kind of take your time with things? Yeah, exactly. Probably no interventions even are necessary at this point, just kind of, routine vitals and things like that. Okay. So these videos are taking a second, so I apologize for the wait. When you guys, just out of curiosity, when you do go into a place like that and you do have a well-looking child, do you feel compelled to bring them to the hospital most times, or can you usually talk parents? Okay. Sure. Perfect. Oh, was it? And did I mess with it? Toggle it? Oh, it's thinking. You see that? Okay. Well, I can just tell you, in general, the things that we look for in pediatric patients in terms of work of breathing, this is not news to you, but are retractions. That's one I think that most people look for immediately. Are they sucking in under their ribs, between the ribs, above their line? And I think there's a general rule that like if the retractions are moving upwards, that's increasing signs of distress, but that's making the assumption that whatever the disease is low and you're working your way up. If you have croup, you're just going to see it right here, right away. So I generally try to think of it as wherever you see pathology, you work your way up or down from whatever that is. And so not to terrify people too much. going. No, that's okay. Sorry for those of you who, for everyone who did. Right, so let's do another one for this kid. So how does this kid look to you? Okay. What makes him look sick to you? He looks, I'm sorry? Sure. And does it seem like he's having a hard time breathing in or a hard time breathing out? In. I agree. And his eyes are closed. He's not interactive. His tone is poor. So yeah, within 2 seconds, you guys can tell that this is a sick kid. His breathing is impaired. What about his circulation? I agree. I think that with all the three things that are going on here, that circulation is still not, hasn't been impaired by what's going on. Oh, I forgot this. So those are just some videos and ones that didn't load of things to look at when you're just assessing a whole patient. Here are some other videos that are going to kind of show us some classic signs of respiratory distress, actually respiratory distress. No, I'm sorry. I put too many videos in my. Okay. That's okay. I'm just going to keep going. This one's going to play. Okay. Huzzah. Okay, so tell me what you guys think about this baby's breathing. What do you see happening? Yep. Where do you see them? Yeah, we'll play it again. Just kidding. This is going out of control here. You saw them underneath the rib cage. Did you see them anywhere else? It's hard to see his neck, but you can kind of see in between his ribs as well. What about his color? Yeah, oh, looks okay. I'm gonna keep playing. What about this kid? What is he doing? Even though it just said it on the screen. Yeah, sometimes I think people think that this is like a cute little thing that babies do, like just they're bebopping in their sleep. And no, head bobbing, even though they don't look distressed anywhere else, is a pretty good sign that they're having a really hard time exchanging air. Okay, so what do you see happening in this one here? Let's see if yeah, that actually has nothing to do with what's going on in this particular video. That's right. He's not breathing. I think that's why they put the little timer on this, is that the kid doesn't look like he's distressed at all. He just isn't breathing at all. So sometimes I think we get this false sense of security because there's not a lot of movement going on. That must mean they're not distressed. But distress doesn't necessarily only mean work. It means absence of work. I think the second most important thing, other than the tunnel vision that we often get in the winter, to remember is the pathology location. So in the adult airway, let's say, an average adult airway is about 10 millimeters in diameter. If they get some kind of viral infectious process, they lose 1 millimeter of that diameter from inflammation. It essentially triples the resistance of air through their airway and reduces the surface area by 45%. That's just 1 millimeter out of 10. So imagine if you have a pediatric airway that has 4 millimeters and they lose 1 millimeter of that diameter from inflammation. It's a huge amount of increased work and resistance and turbulence that occurs in that airway. So even though it doesn't seem like a big deal because their airway is this long, whether you're talking about like the throat or the larynx or the trachea, it's the difference between life and death in some cases. So So just to kind of give you a general map, when we think about the airway and the noises that we hear in the airway, from top to bottom, snoring, which I think probably many of us do, but also kids, not pointing fingers, a lot of kids do. But the more pathology occurs right about the time that you get around the vocal cords. Right above the vocal cords, if you have inflammation and swelling, that's the most commonly croup. You can have stridor. You can have biphasic stridor at or below the vocal cords, either from croup or foreign body. You can have wheezing in the bronchi or bronchioles, which is lower down and is shown by the circle, kind of in the actual airway itself. Crackles are heard in lung tissue. And then disordered breathing is a brain issue. So if you kind of remember this map, it's helpful when you actually come face to face with the particular issues. So for example, there's a point. There's an actual one I want you to listen to. These are just have to listen to until we get there. This is just a mean wife or somebody. This one here, this little baby. This is a pretty common sound I think we hear when we go and pick up babies or take care of babies in the emergency department. So what sound is this that we're hearing? This is not rocket science, but exactly. So it's snoring or stridor is the medical term for it. Okay, and so the location is up here. So when you hear that noise, you have to think about the nasopharynx. You don't have to, but it's... All right, here's another one. So what kind of noise do you hear? Yeah, an inspiratory noise. It sounds like stridor. And then where does that occur? Yep. Right at or above the larynx. We'll skip the biphasic stridor. And this is the sound of wheezing. It's just kind of hard without a stethoscope. If you get close enough to some of these kids, you can hear it's an expiratory noise, it's high pitched, and it's whistling. And this is an important thing to differentiate, which we'll talk about a little bit later, but where is the pathology of wheezing? In the actual path of air in the lungs, not in the lung tissue, but in the pathway of air, and we'll talk about that in a little bit. Oops. Okay. This one doesn't leave anything to wonder, does it? When you listen to crackles, it sounds different than wheezing. It's not high pitched. It's turbulent. We'll listen here about crackles. And where in the airway do crackles occur? They can for sure occur there, but it also most commonly, like I guess classically, occurs in the lung tissue itself. So things like swelling of the lungs, which babies can have, or pneumonia, which can happen in kids, but more often adults. Also, it's the location. So like you're listening to a baby and you hear that everywhere. Well, that's probably more likely it would be bronchiolitis, but if you listen into one area and you're hearing it, then more likely the things that you're talking about, like in the airway itself. So, all right, here we go. It's kind of hard to see. So does he look sick? Does he look like he's breathing? Yes, that's exactly what's happening. He's having a seizure. So what kind of breathing happens during a seizure often, or classically? Yeah, it's for sure, it's what we call disordered control of breathing. So their brain is misfiring and their respiratory center is taking a hit and they can't figure out what the right way to breathe is. So when we're talking about location, it's in the brain. Okay. Another case. You arrive in the home of an 18-month-old female with report of respiratory distress. Parents called 911 after dinner when she started vomiting. When you arrive, you see a fussy baby, but she's vigorous. She's belly breathing and auditory, or you can hear her breathing. Parents are in a panic, so the only information you can gather is that she had a cold over the last 1 week. She has a history of eczema, and she tried mangoes for the first time tonight. You listen to the patient, and you hear a high-pitched inspiratory noise. What do you think is going on with this patient? Certainly could be. You have a high-pitched inspiratory noise. Where in the airway would you think that would occur? Right, in the upper airway. So you have stridor and you have high-pitched inspiratory noise. There's all these different things that it could be. And while you're sitting there taking your vital signs, all of a sudden she starts to have this all over her body. So now what are you thinking? Yeah, allergic reaction to mangoes. And, you know, when you're taking a test, they usually don't give you all these confounding variables. But, you know, I think when you guys go and collect information, you don't get it as neat and tidied in a bow as that. And so when you hear high-pitched inspiratory noise and a rash and respiratory distress, what do you have to be thinking about in the future that you want to protect or prevent happening? Absolutely, or complete obstruction. So you don't want this, you don't want it to the point where you lose your airway completely. So stridor, which we just kind of talked about as a noise in and of itself and where it's located, can be caused by lots of different things. It's not always croup, even though that is the most common cause of stridor in kids. The most common cause overall, I think, is infectious. So croup being the #1 cause, bacterial tracheitis and epiglottitis, which we're seeing less and less of these days, and sometimes whooping cough. If you have a history that they were playing with some toys and then there was some choking and then there was this high-pitched inspiratory noise, you have to think of whether they choked or gagged on a toy, now it's sitting in their airway. We kind of went over anaphylaxis. And then there are those some chronic kids that you guys are probably used to, frequent flyers, that have abnormal airway anatomy that just are stridulous all the time. I think the #1 respiratory thing we see, at least in the emergency department in kids, is wheezing. And I think this is like one of the biggest issues that at least we have in pediatric emergency medicine, is differentiating the difference between bronchiolitis wheezing and asthmatic wheezing. And when I'm talking about how kind of conceptualizing anatomically what's going on in the airway to make it more clear, it's not, I say this tongue in cheek, it's not as difficult if you think about it physiologically. So a kid that has bronchiolitis has a viral infection. Their airways are inflamed. The inflammation of their airways causes all this gunk to go into the airways, and then they breathe through that gunk, and it makes a high-pitched noise like wheezing. Like, it sounds like wheezing, and it is wheezing because it's the definition of wheezing, but it's because there's stuff in the airway that's making it hard for air exchange to occur. Whereas if you think about an asthmatic, they may have some secretions in their airway, but really it is about their airways themselves. When I tell parents, I call them twitchy airways. They freak out really easily, and they go, and they just close up really fast. There's not a lot of schmutz in there to suction out or get out to cause a wheezing to resolve. You have to do something that's going to relax the airways themselves. And so the pathology is so different that, of course, the interventions are going to be different. I think we oftentimes jump to do something like give albuterol or steroids or something because we want to have some kind of intervention to provide relief when it's not targeted pathology and it's probably not the best option. Crackles, we use the term crackles and bronchi interchangeably, although technically they're a little bit different. There's just coarse breath sounds. And oftentimes we use the term crackles when we're talking about broncholytics because they have all that schmutz, again, or stuff in the airway that's causing turbulence when they're breathing in and out. It's really important, especially in young kids. Kids get pneumonia. It's not out of the realm of normal, but it is much less likely for them to get like a community-acquired pneumonia than it is for them to get a viral infection. And so the intervention, again, is going to be different. If you're listening to them and you are listening and you're clear, and then, that suggestive of something actually focal going on, like a pneumonia, so you need to intervene differently. This is the one where I think we often see people coming in with this underlying thought of there is a respiratory infection and we have to intervene because there is respiratory changes that occur or altered mental status occur with respiratory changes that we think about last when we probably should be thinking about it all at once if possible. The disordered control of breathing, which is probably more common, I think, in kids in a lot of ways than adults sometimes for different reasons, which we'll go over. In adults and kids, it's the same. If they have a seizure, their brain's misfiring, neurons are firing all over the place, their respiratory center is not functioning properly, they're not going to breathe properly. There are other toxins, things like aspirin ingestion or opiates that will affect a kid's respiratory drive, so it's always important to think of those. Uncommonly, there's stroke, and there's other things that come with stroke that you guys know about. We won't go too much into that. I oftentimes see kids who are actually in florid DKA come in with the diagnosis of pneumonia or bronchiolitis or viral pneumonia. And it's the interventions are clearly very different, so it's important to make that distinction. The one that we're seeing quite a bit of now is RSV bronchiolitis and the apnea that can come along with that. Like that one kid whose video we watched a couple minutes ago who just looked like he was just fine and dandy, he wasn't working at all. If that goes on longer and longer and longer, that is setting a kid up for what I was talking about earlier. They're fine until they're not. So it's important to intervene early. Okay. Here's another case. You have a 3-year-old male with reports of respiratory distress. When you arrive, the parents report 3 days of high fever, cough, congestion, and poor oral intake. You walk into the child's room, and this is what you see. Okay. What do you guys think is going on here? Is he sick or not sick? How is his airway doing? And why not? What do you guys hear happening? Absolutely. How about his circulation? He looks sick. He's got inspiratory stridor. Yeah, it's kind of like 1970s lighting in there, but he's got good color. He's still pink. He's still got pink lips. They're maybe a little bit dry. Not too bad. He's a sick kid with what we think is an upper airway obstruction. Oops, forgetting about that TS, sorry. Always in the middle of the night, yeah. Yeah, oh, that's classic. And then the other things, okay, I'm automatically. The other thing to think about is, what are some of the important questions when you're going to take care of this kid? I mean, you think, okay, I'm going to do my racemic epinephrine, I'm going to do my steroids. What are some important questions that will make you either like come lights and sirens or make you do other interventions other than those things that we already kind of know that are going to happen? Absolutely. How long has he been in this condition? Absolutely. You want to know, is he teetering towards the edge of collapse, or is he kind of just, is this a first state of illness? Another important question to ask is immunization status. You know, we don't see epiglottitis or bacterial tracheitis as much as we used to, but they do still exist, and we see them in unimmunized kids on an infrequent basis. Other things are, think about are, you can have abscesses in the airway that can cause the exact same presentation as croup, and those are not going anywhere until they're surgically drained. So no matter what you do, it's not going to make it better. So just keep that in the back of your mind when you're doing your intervention. The number one thing I think to do, especially in little kids, when we're talking about those airways where 1 millimeter of difference makes all the difference in the world, is a position of comfort. Like we mentioned before, it seems kind of intuitive for all of us to be like, we are going to heal you, so please lay down and, you know, use this pillow. We're here to help you. When laying down can be the worst thing possible for them. You want them to be calm, to be breathing in a way that's comfortable for them and keeping that airway as patent as possible. So this kid here, he's tripoding, but that's okay. It scares us, but that's his body telling him this is the way that I'm going to get the most air in. With regards to treatment of these different pathologies, we kind of know those a little bit. I don't know how much you guys are doing suctioning in the field. Is that something that happens? I was going to say, that's my next talk, my next slide, but so talking about suction, there are times where kids rightfully, 911's called, parents are freaked out, totally working hard to breathe, brought in, and all we do is suction out their nose and send them home. Because babies, especially babies less than 12 months old, are what we call obligate nose breathers. So they will always preferentially breathe through their nose before they breathe through their mouth, even if they have giant, like, wine corks. They'll still try to breathe through their nose before their mouth. So they're going to be in floor distress, even though all you got to do is remove whatever the obstruction is, and that can sometimes keep them at home and spare them an ED visit. Oh, are you familiar with the nose Frida? You describe it to parents and they get this look on their face like, oh God. But there's a filter between what she's sucking and that baby's nose, so she's protected. And even like talking to families about that, like a nose free, like the bulb doesn't really do very much. I don't know what kind of suction you guys have, but nose Fridas work great. There's this thing called a baby vac that works really, really great, but you connect it to your vacuum. It's kind of intense. But there's different tools at home that can keep them at home, which is nice. Oh, is that universal? Okay. So, and I am to tell you that new EMS protocols do include suction as one of the steps in a respiratory pathway for kids. Moving down the airway, we already kind of know croup bacterial tracheitis, epiglottitis. The treatment is steroids and racemic epinephrine. I don't know how much information you want to collect while you're taking care of these kids, but if you have a kid who has croup and you give them steroids and you give them racemic epinephrine, and like usually within minutes, you'll see a difference. You'll see the stridor decrease, or work of breathing decrease. Oftentimes, if you have these other conditions that are more severe, such as epiglottitis or bacterial tracheitis, you give them those things and you don't really see much of a change. So that might be a reason to take pause to say, oh, well, we may need to get where we're going a little bit faster because these kids tend to be more critically ill more quickly. Anaphylaxis causes upper airway obstruction because of a histamine response. So histamine's released, your body freaks out, all the fluid in your body goes into the soft tissues and swells everything, the tongue, the lips, the airway. So you can have an upper airway obstruction, and it's really hard to get past if you're not proactive about it. So just being on the early end of treatment. I remember when I was in residency, I had this talk from someone who was an expert in anaphylaxis, and the treatment is IM epinephrine. I mean, you know this already. This is not expert material. But if you think that a kid might have anaphylaxis, but you're not sure, give IM epinephrine. If you even smell the possibility of anaphylaxis, it's okay to give IM epinephrine. It's not going to make them feel great. It's much more harmful for them to not be treated for evolving anaphylaxis than it is for them to get a little jolt of neurotransmitter that's normal to their body that they can get rid of in a reasonable amount of time. So don't hesitate. Oh, okay. It is, and we can kind of go over, that's actually a really good question, because I think that's the thing that we see happening sometimes just because you use whatever's in your toolkit, right? So racemic epinephrine has a mechanism of action where it acts on swollen blood vessels, and it makes the blood vessels go, I keep doing this noise, it looks like a sphincter, but anyways. So it goes, and then like the blood vessels contract, all the fluid gets pulled back in, the swelling goes down. So then that swollen area becomes less swollen, and so that the breathing becomes more easy. Albuterol, it has a bronchodilator effect on actual like airway, not necessarily on just the soft tissue around the airway. So it opens up lower airway in the lungs. So if you don't have racemic epinephrine as part of within your toolkit, you guys can use cool mist nebulizers and oh. So when you see a kid, like again, for me, when I see a sick kid, I try to think about what's going on in the body, and I hear the stridor and they're febrile and they're having a cough. If you look at these two pictures, now that we're back here, the larynx itself is fine, but you see how the soft tissue around the larynx is really swollen. So the racemic epinephrine is going to be useful in that, and albuterol will not be helpful for that. The cool mist, the cold, has a similar effect as epinephrine does. It makes those swollen blood vessels contract, like when you get cold and you go outside and your hands get purple, it's because all your blood vessels are constricted. And so cool mist or racemic epinephrine is helpful for this, whereas when we go to, wheezing, which we'll talk about later, it's actually opening airways themselves. The other stuff, if you have it, again, everybody carries different things. Things like Benadryl, steroids, ranitidine, albuterol, all those things can be helpful in anaphylaxis. There's not a ton of evidence to support it. But if someone has anaphylaxis, you've already given the epinephrine because you didn't even hesitate, and then the other stuff can only help. It's not going to hurt that kid. I think one of the scariest things that whenever I get a phone call, speaking of sphincters clenching, is a foreign body in the airway. I'm sure you already know some of these techniques. In general, the rule of thumb is, they say 2 years of age or less if there is something in the airway and you want to give them back blows or thrusts to remove it. You have to be able to hold them kind of in the length of your forearm. If some of the kids that we see are giants, so if they're 6 months old and you can barely do it, you can do some of the other more advanced like Heimlich maneuver type stuff. But for kids in general, less than 2, put them in your arm. You do 5 back blows and you do some chest thrusts. I think our angst makes us want to see if there's something there that we can like scoop out, but with that really tiny airway, whatever we're going to put in there is more likely than not just going to push it farther down. So unless you see it right there and you know that you can get behind it, it's not really a great idea to go after. I know in adults, you guys have those giant, terrifying looking clamps. I don't know if you do that in kids or not, but in general, it's better to do this kind of increasing the thoracic pressure maneuvers than it is to go after it directly. And we kind of broached upon this earlier. Bronchiolitis is the #1 diagnosis that we see all winter long. All day, every day bronchiolitis. We become a little bit bitter about it by the end of the winter. But the pathophysiology of bronchiolitis, like we talked about before, is inflammation of the airways, schmutz in the airways, and they try to breathe through it and they can't get through it. So the gas exchange doesn't do very well. So we've tried, because it's the #1 thing that we ever see, doing everything. We've tried steroids, we've tried breathing treatments, we've tried antibiotics, everything. And the only things that really work with a kid with bronchiolitis are suction, oxygen if they need it, respiratory support if they need it. And then that question of albuterol comes up. If you hear wheezing, in general, in a kid less than 2 that's wheezing that doesn't have a history of asthma, not really indicated to use albuterol, even though everything in every fiber of our being tells us we want to do something to help that kid. These interventions aren't innocuous. It can be tachycardic and make them more agitated and kind of cloud the clinical picture. Oftentimes when we use humidified nebulized treatments, we're moving those secretions around. So then they sound better. And we're like, oh, we fixed them. And it must be because they needed albuterol. And it kind of sends us down this rabbit hole. So in general, suction and oxygen are the most important things. I know now some teams are carrying high flow nasal cannula. And then if nothing else, if nothing that you're doing is making air movement better, then non-invasive positive pressure is the next step. Albuterol is generally reserved for those kids that we know it works for. Having said, if you give it and it works, pneumonia, the definitive treatment for pneumonia is antibiotics. If a kid's, in general, I think you probably are doing this if they have like signs of sepsis or septic shock. Not as important, but it's oxygen and antibiotics are going to be the most important in these kids. And going back to the asthma again, I can't drive this point home. Asthma is different than bronchiolitis in that the airway itself is just closed. It's not necessarily filled with stuff. It can be a little bit, but it's not the primary driver to their respiratory distress. So the definitive treatment for an asthma exacerbation is steroids, but it takes a really long time for steroids to start to work. So you get the steroids in them as quickly as you can. And then you start giving them the other things that you know work for asthma. Things that are like bronchodilators like albuterol and oxygen. And then some kids who are so clamped down will need something to help blow them open, like bag valve mask or CPAP or BiPAP, whatever you guys are using. You guys have magnesium? I don't know if you guys are using magnesium. And going back to this one, I think this is one of my favorite topic or favorite areas of this particular talk is this concept of disordered control of breathing. The number one cause in kids is most often seizure, at least that we see on a regular basis. So the treatment is support their ABCs, of course, but also a reversal agent. So whatever they're doing to seize, quiet the brain to reconnect those pathways so that they're correct, so they can breathe on their own, things like benzos. And if doing that makes them not breathe, or because they're so disordered, you have to breathe for them, having your bag valve mask ready. And then oftentimes these kids that we see seizing, not breathing right, are having febrile seizures. It's a pretty common, I think, type of seizure that we all see. So giving them an antipyretic to get that. You have a question, Hillary? That's a really good point. Hillary brings up that we should consider putting in nasal trumpets for these kids to help keep their airway patent so that when they do wake up, which they always will abruptly, that they don't freak out, choke on the oral airway and cause bigger issues. And then toxins being opiates, aspirin, reversal agents, like Narcan. Another cause of disordered breathing, like you had mentioned earlier, was your body compensates for DKA by breathing hard and fast. It's a scary appearance as though they are in fluid distress, and their body is, but it's not necessarily a lung pathology. I remember someone telling me, an endocrinologist telling me once, every kid that has DKA has brain swelling. So you think about every kid that you're taking care of with DKA as their brain is swollen. So it's elevating the head of their bed, giving them IV fluids. And do you give insulin? No. Insulin is the definitive treatment, but IV fluids and supportive care until that can happen is just as important. And then the one that's most appropriate and that we're seeing now is RSV bronchiolitis and the apnea that comes with it. And the only way to really remedy that, at least in the field, is bag valve mask ventilation, breathing for them. Oftentimes they're at the point where they won't even fight you. They don't really are connecting with their respiratory drive. But even if they do, it's important to keep doing it for them because they won't remind themselves to do it. And then if that doesn't work, BiPAP, BPAP. Oh yeah, so in general, the most at risk are 1 month of age and less, but in general, like I've seen 3 and 4 monthers that don't do it either. So just really tiny, fresh babies in that first 3 months of life are the ones that are most commonly going to have that happen. Yeah, definitely for kids less than 3 months. Hillary brings up a good point. Kids less than 3 months that you are believing have some kind of respiratory distress, bronchiolitis. We don't want to obscure our view of their respiratory drive while they're in transport. So even though we want to keep them warm, we can do that by putting loose blankets on them so that we can watch chest rise, air movement, and the respiratory rate while they're being transported. Okay. So this kind of puts it all together in terms of the goals of today's talk. So you get an urgent call. It's mid-January. You have a 1-month-old male reportedly not breathing right. When you arrive, the parents report that the patient was born at full term without complications. Mom used methadone during pregnancy. Baby has cough and congestion over 1 week. Over the course of the last week has also had increased fussiness and spit up. When you arrive, you see a listless infant. Tone is low. He opens his eyes to stimulation only. His vitals, his temperature is 36. His heart rate is 140. His respiratory rate is 10, and he's setting 84% in room air. What do you think's going on? And just to clarify, there's not one right answer. There's lots of things that could be going on. So what are the things that pop into your head? What things do you think could be the underlying cause of his respiratory issues? That's a great thought. Absolutely. So a toxin, so either methadone, or I've actually seen some kids come in where parents are like, oh, they're really fussy, and I just gave them some of my medicine to make them sleep better, you know. In case anyone online can't see, everyone just went in the audience. What else could be going on? Cough and congestion for 1 week. Okay, he's fussy, but he's been spitting up more. But he could have bronchiolitis, he could have pneumonia. He's fussy. Fussy babies, sometimes bad things happen to them because parents do bad things to them. They've aspirated. I mean, the point, I guess, really is that these kids, even though it's mid-January, he's had cough and cold. There's a lot of, all of us are, and the likelihood is that this is a respiratory viral illness. It's really important to try to get our heads out of the ruts that we all get in. Think about these kids as just viral respiratory breathers, and that there's other things that could be going on with this kid. I mean, he's breathing 10, so it's either because maybe he had a seizure, maybe he got meds from mom and dad, you know, maybe he's just lost his respiratory drive because he's tired out. It's really hard to say. So it's important to think about all those things. So in summary, the most important thing that I wanted to take away from this talk is approaching each breather with an open mind. Not all seemingly respiratory kids have a respiratory pathology. Making sure that we target the location of the disease, because like we talked about with croup and albuterol, they're this far away from one another, but the treatment is going to have vastly different responses. And then tailoring the treatments specifically to what's going on. Question? Thanks for having me. Let's start twitching. Yeah, so the question was about coronavirus, whether we're seeing it in children and whether there are any respiratory considerations. In Utah, there have not been any, at least over the last 24 hours, there have not been any documented cases of pediatric coronavirus. The vast majority of the time when there have been pediatric cases, it is mild. So a mild respiratory illness. And by mild, I mean things like flu, which wreak havoc on any human being, but it's not necessarily imminently life-threatening in every single case. And I think the youngest death has been in a chronic teenager, or was a 10-year-old? They were a chronic 10-year-old, or chronically ill 10-year-old, I believe. So it's not something, it's something to always think about, to take precautions to make sure that everyone is doing lots of hand washing and avoiding non-essential type interactions with people, you know, not licking the walls of the bathroom whenever they go to the mall, those, you know, the things that kids tend to want to do. But for the most part, it's not something that should be causing hysteria, at least amongst parents worrying about their children at the moment. It's definitely different for the elderly, but luckily I'm not an elderly doctor. So the question was about PPE for those that are in the field with regards to coronavirus, and currently you guys are wearing masks, gown, and gloves, and eye protection. That's, I think, one that has become more prominent with this particular virus is the consistent use of eye protection. Difference and masking patients as well. Not transporting if not critical. I know that in the emergency department, we have new protocols that are in place in order to help prevent transmission. And they're really driving the point home that the difference between your risk walking into a room without eye protection versus with eye protection is very significant. So it's not something to just be like, oh, I'm just not going to use this. This is one time. I think that's probably that and gloves are going to be the things that are going to protect you the most. So. Yeah, and that's another good point is that if there's a established concern about this being coronavirus, communicating with wherever we're landing, where you guys are landing, or if we are directing to make it clear that that's what we're concerned about so that we can take the proper precautions to put them in the right room or in the right part of the emergency department. Because with one, not like a kid or adult doesn't disclose that concern and exposes 30 staff members, you've just taken out a third of our medical staff under quarantine, and then which puts more strain on the workforce. And that's what I think the biggest concern, at least with kids now, is not so much that they're suffering because of the severity of the illness, but the concern for transmission and exposure and the quarantine that results because of it is really causing a hit to the workforce. There's this funny meme where there's a PICU nurse gowning up to get into a room, like and there's like an emergency room nurse gowning up, and it's like Brad Pitt from Fight Club with like a cigarette hanging out of his mouth. Like we're not used to doing that. I don't know if you guys are used to doing it, but if you're not, it's time. Like I'm not used to it. I hate it, but I'm trying to be more mindful of it. Can you repeat that? Yes, I can. Sorry, 1 ml of epi and. Oh. Okay. So we were talking about how those who don't have already racemic epinephrine can make it in the field. If you take 2 milliliters of 1 to 1,000 epinephrine and mix it with 3 milliliters of NS, for a total of 5 mils, that can be used as a nebulized treatment for croup. All right. Thanks, guys. Thanks, Tia.
Thank you, everyone in the room and online. And thank you to Sarah. Wonderful presentation on respiratory. That's always the #1 reason that EMS is called for pediatric patients is respiratory complaints, even more than trauma. So this is the big one, the cash cow for our pediatric patients. If you want a certificate, you need to follow the process that is listed online right now. If you're in this room, you make sure you've signed the sign-in sheet, and I'll send it to you via email. If you're watching right now, live, just shoot an email to utah.petos@gmail.com. I'll get you the questions and we'll get that certificate turned around to you in a couple days. And then you can also watch these things on archive. Be aware that the new Utah protocol guidelines for EMS are now released. The 2020 version is now online. They've been updated. There's a great PEDS track on them, so you can go and look at your PEDS care along with your adult care. So that's a great resource for you, and it's accessible to anyone who cares to look at it. Enjoy this next month for another PETOS.